Welcome everyone to Cascades Analytics Live. My name is Alexandre Stepanovic, and I'm the founder of Cascades Analytics, a media and consulting bureau investigating the frontiers of psychedelic and neuroplastic psychiatry. Here we speak with the scientists and founders shaping the next wave of psychiatric drugs. Today, I'm thrilled to welcome Professor David Olson, Professor of Chemistry and Biochemistry at the University of California, Davis, and founding director of the Institute for Psychedelics and Neurotherapeutics. Dr. Olson's lab coined the term psychoplastogens and has led the field in understanding how psychedelics promote antidepressant phenotypes and how we might design safer versions by removing the hallucinogenic effects. He's also the co-founder of Delix Therapeutics, the biotech developing the first generation of non-hallucinogenic neuroplastogens, including DLX1, now advancing through clinical trials, the first and only neuroplastogen currently in the clinic. David, it's a pleasure to have you.
Thanks for having me here.
Yes, let's start with our first question. Could you explain a little bit the mission of the IPN and some of the ongoing projects?
Sure. So the Institute for Psychedelics at UC Davis really has a two-part mission. Number one is to better understand the mechanisms of psychedelic drugs, how they impact brain function. And number two, to use that information to design better drugs, better neurotherapeutics for treating a range of neuropsychiatric and neurodegenerative conditions.
And who are your current partners? You mentioned you were working with a myriad of biotechs there.
Yeah, so the first thing to emphasize, I guess, is that this is the first investment in a psychedelic science center by a major university. So UC Davis, really put their money where their mouth was and provided a lot of seed funding to get the institute up and running. We now have over 80 faculty affiliates spanning a wide range of disciplines. So each person brings their own unique expertise, and that allows us to interrogate psychedelic drug action and develop new neurotherapeutics in a very holistic manner. One of our goals really is to do academic drug discovery. And so we have not only been doing a lot of basic, neuroscience related to psychedelics, but we've been developing new compounds. And we've been partnering with industry leaders to try to take those academic discoveries and translate them to the clinic, because the ultimate goal of the IPN is really to make new medicines for patients. And so as an example, some of the compounds that we developed at the IPN have been licensed to pharmaceutical companies. One company that we're going to talk about today, which I'm a co-founder of, is Delix Therapeutics. They have licensed a bunch of compounds from UC Davis. But we've worked with a variety of other partners in this space. Some of them want to test their own compounds in the various bespoke assays that the IPN has developed. Others want to do basic science to try to understand mechanisms a little better. Some are developing new technology, and they're trying to partner with us to advance that. And so it's really kind of a big effort, not only within the academic community at UC Davis, but we extend beyond that to partners in industry as well.
Okay, and how big is the facility? Do you have all the translational steps from preclinical to clinical?
Yeah, so the nice thing about the IPN is we have a dedicated pharmacology space where we do, a lot of our basic drug screening. So all of kind of the cellular, molecular assays, binding assays, functional assays, high content imaging to look at plasticity phenotypes. We also have access to all of our affiliates' labs. And like I said, that's 80 faculty affiliates. It includes my own personal lab space, which has additional behavioral pharmacology equipment, in vivo systems neuroscience equipment. So you can do fiber photometry and optogenetics. And we have other experts who, have their own areas of specialty, and all of their equipment is available for those types of projects. And so, if a partner is interested in, disease A, we'll pair them with a person at UC Davis who is the world expert in disease A, and they have all the equipment and facilities necessarily to run those studies.
Wow, that's impressive. Now let's dive into the neuroplastogen concept. What first convinced you that neuroplasticity could be uncoupled from hallucination?
Well, I think the first thing to think about is, we were trying to understand what is the commonality between all antidepressant therapeutic modalities, be they pharmacologic or non-pharmacologic. And something that was very obvious is that, it doesn't matter if it's an SSRI, if it's ECT, TMS, acute sleep deprivation, exercise. They all do something very important, and that is promote the growth of neurons in the prefrontal cortex. And so we really thought that was the underlying mechanism by which all of these different treatment modalities were producing antidepressant responses. Where we got very interested in this space was around the time that there was a lot of really great mechanistic work being done by people like the late Ron Duman and George Akajanian around how ketamine produced these neuroplasticity effects. Ketamine seemed to be very unique compared to a lot of these other pharmacological agents in the past, like traditional antidepressants, SSRIs, et cetera. SSRIs are known to promote cortical neuron growth, but they do so on a timescale that correlates with their therapeutic efficacy. You have to take the drug daily for weeks to months before you see any kind of change in structural plasticity and, of course, the therapeutic benefit. Ketamine seemed to be unique. It seemed to promote the growth of these neurons rapidly within 24 hours and very robustly. And the other thing about ketamine that was very interesting is that in addition to these rapid and durable effects that lasted long after the drug was cleared from the body, it seemed to work across disease indications. And we reasoned that was probably because it was targeting a critical hub in the brain, the prefrontal cortex. The PFC projects to a whole bunch of subcortical regions that regulate things like mood, motivation, fear, reward, cognition. And so it's perhaps unsurprising that if you can address PFC dysfunction, you might have a therapeutic that can work across a range of conditions. And so when we started in this area way back in 2015, we were looking for drugs that had ketamine-like effects on neuronal structure, but might have some advantages in terms of their efficacy and or safety profiles. And so one of the first classes of drugs that we started studying were the classic serotonergic psychedelics like LSD, psilocin, MDMA, 5-MeO, DMT, et cetera. And then we added on a few other, call them atypical psychedelics like MDMA and ibogaine. And what we found was pretty interesting is that this ability to promote cortical neuron growth seemed to be a shared property of these compounds. So ketamine was not the only drug that could do this. And so to kind of differentiate these types of plasticity promoting compounds from traditional antidepressants, we coined the term psychoplastogen to really kind of emphasize the rapidity of the effect and the durability of the effect. Now, the next question that really we posed was, could you separate the hallucinogenic effects of the drugs from their effects on neuroplasticity and their sustained therapeutic behavioral effects? At the time, we reasoned that it might be possible to do this for a variety of reasons. Number one, all of those other antidepressant modalities that promote plasticity, they don't seem to produce hallucinations. So it's clear that you don't need a hallucinogenic effect to get an antidepressant response. The question was really, with these hallucinogenic first-generation psychoplastogens, is their biology amenable to being kind of just tweaked a little bit to remove that hallucinogenic potential? And so we started trying to answer this question in a variety of different ways. Well, the first thing we did is we used dose. So we started dosing animals with, sub-hallucinogenic doses, and we found that we could still get the same plasticity effects and the beneficial sustained behavioral effects, even with sub-hallucinogenic doses. Now, of course, microdosing is not a great therapeutic strategy because people could simply take multiple pills to achieve high hallucinogenic doses. So there's still abuse potential. And so it's still not a very scalable approach. But we wanted to know if maybe the circuitry was a little different between the therapeutic response and the hallucinogenic response. So for those studies, we teamed up with a former colleague of mine, Tita Kim, and we used a really interesting genetic tool called SC-FLARE, where that allowed us to basically tag psychedelic responsive neurons in the prefrontal cortex and then optogenetically stimulate them after the drug has been cleared from the body. And what that allowed us to do was to drive a therapeutic behavioral response without driving the typical acute hallucinogenic response of the drugs, suggesting that the circuits might be distinct. And if the circuits are distinct, we might be able to be very clever with our pharmacological design to make drugs that selectively activate the therapeutic circuits without activating the hallucinogenic circuits. And so, at the time, we didn't know a lot about mechanism, and so we simply started making analogs of every single major psychedelic scaffold that we knew of. Tryptamines like DMT, ergolines like LSD, iboga compounds, etc. There was a lot of structure-activity relationship studies that were performed by people like Dave Nichols and Richard Glennon and others, and there's a lot of there's a lot of information from psychonauts who have been trying to make new compounds and evaluate their effects on humans. And so we took all of that information and we looked for compounds that did not produce hallucinogenic effects, at least either in people or in animals. And we looked at their structures and we looked at the structures of the psychoplastogens, and we kind of combined them. We took aspects of both to engineer novel compounds that would have lower hallucinogenic potential, reduce cardiotoxicity, reduce psychostimulant properties, but maintain the ability to promote cortical neuron growth. And that was really the premise behind the development of neuroplastogens or non-hallucinogenic psychoplastogens. And I guess, there's one other piece of information that I should have mentioned. Another reason I thought this was possible to do is because early on we took bona fide non-hallucinogenic compounds that were analogs of psychedelics. They had been tested in people in clinical trials. And we took those and we put them through our plasticity assays, and we found that it was possible for them to promote cortical neuron growth. So that gave us some more reason to believe that it would be possible to do this.
So not one single aha moment, but probably multiple aha moments in the lab.
That's right. There wasn't like, it was more of a question when we started. We didn't honestly know the answer. We didn't really know if it was possible. And we started pursuing these different tracks, making analogs, doing the low hallucinogenic doses, doing the circuitry analysis, all at the same time. And they all, converged on the same answer.
Mm-hmm. Mm-hmm. So let's delve into GLX-1, the first compound that you have in clinical trial right now. In your recent ACS paper, you report that DLX1 increased SEPSC frequency and amplitude, as well as spinogenesis, philopodia, and mushroom-type synapses, alongside behavioral effects. And the test you use is immobility in the forced swim test. I remember working on side note, but I remember working on psychostimulants myself 15 years ago, 20 years ago. Psychedelics were to avoid because there was no good behavioral test in rodents. And now, we're revisiting this. So anyway, back to DLX1. You see at every, you integrate very nicely the effects of DLX on various phenotypes. So SEPSC, spinogenesis, and behavior. Did you try to block 5-HT2A receptors with, for example, ketanserin to see if we would attenuate any of these readouts?
Yes. So the first thing I'll say, so DLX1, it's also called zalsupindole. We previously called it AAZ. It's been investigated in several published studies so far, and Delix has a very, very robust preclinical package for this compound showing efficacy. The first thing I want to say is that this compound was reverse engineered from first generation psychedelics. Particularly, it takes structural elements of 5-methoxy-DMT and MDMA and kind of hybridizes them, like I said, in order to achieve oral bioavailability and to achieve a very, potent neuroplastic effect. And so we've tested, this compound in a variety of different assays. You asked about ketanserin and whether you can block some of the effects with a 5-HT2A antagonist, and the answer is yes. And there's a couple of published papers on this already. So the plasticity promoting effects of DLX1 or zalsupindole seem to be dependent on 5-HT2A activity, just like they are for 5-MeO-DMT, which we've also published on. The thing that is really interesting about this whole class, though, is the sustained effects. And you mentioned the behavioral assays that were used. And this is something that in, I think, psychopharmacology, it's very challenging to study the effects of a drug because acute effects of the drug will usually do something to an animal. But the advantage of studying psychoplastogens is that you don't have to measure the acute effects of the drug. You can measure the sustained effects of the drug long after the drug has been cleared from the body. And so we know that if you give a psychedelic or if you give zalsupindole and you wait until the drug is cleared from the body, you can then still see these changes in structural and functional neuroplasticity, and you can see these long-lasting therapeutic behavioral effects. Now, you mentioned just one example of a therapeutic behavioral effect. We can compare zalsupindole head-to-head with compounds that have clinical efficacy like ketamine, and we see that it has the same rapidity of effect. So it works, very, very rapidly, and it lasts for at least, a week to 2 weeks after a single dose in preclinical animals. And now we're seeing from some of the recent clinical data that was just announced today, actually, that zalsupindole is seeming to produce sustained effects in the clinic as well.
Well, that's huge. We're gonna come back on that later, but congratulations on that, and that's fascinating, a huge milestone. Back to the paper, the ACS paper. You see also a nice dose response of zalsupindole on spine density, and so at 10, 20, 30 mg per kg, you see stronger spine effects. And did that correlate? Do those, higher doses correlate with other phenotypes?
So something to keep in mind is that this study that you're talking about was all done in wild type, otherwise healthy rodents.
Right.
And to get plasticity responses in healthy animals, you need to use pretty high doses in general. And that's true of psychedelics as well. Like, you can't use a very, very low dose and see things above baseline. And the reason for that is because the brain has homeostatic mechanisms to keep, synaptogenesis in check. You don't want to have a whole bunch of new synapses being made because that can lead to things like, seizures, et cetera. So if you make a few new synapses, then usually the brain, calls them back. So, but what we have shown with other compounds is that if you provide some kind of stress model and you induce atrophy, induce a deficit, then you can use very low doses of these compounds to get a rescue of that effect. So in this case, we do see a dose-dependent increase in spine growth with zalsupindole, but the behavioral effects actually turn on at the lowest doses. So you don't really need that much to produce a very long-lasting therapeutic behavioral effect. Is that the question you were asking?
Yeah, I guess if you don't need it, why investigate it? If the lowest dose works fine, it's what you need.
Well, it's important to recognize that there's a PK/PD dissociation with all psychoplastogens. And that what I mean by that is you don't have to have the drug on board in order to produce a therapeutic response. And the responses seem to be driven by the maximal concentration in the brain, the Cmax, rather than the area under the curve, how much drug is in the brain for a long period of time. And so there is a concentration response, meaning that as you increase the amount of drug in the brain, you get a bigger effect. And we observe this in animals, but we've also observed this now in patients, in humans.
Mm-hmm, mm-hmm. And for 5-HT2A centric compounds, what's, in your opinion, what's more predictive of an hallucinogenic potential? Is it the signaling bias, like GQ versus beta-arrestin? Is this still relevant? Is it more about receptor localization, microdomain, residence time in the receptor, or Cmax, or
It's a difficult question to answer, but I think what I can say is, our opinion in the, what I think is becoming the prevailing opinion in the field is that partial agonism of 5-HT2A receptors is a way to maintain the plasticity promoting effects of the drugs while eliminating the hallucinogenic effects. All psychedelics are very high potency, high efficacy agonists of the 5-HT2A receptor. All of the non-hallucinogenic compounds that are currently being developed, from what I can tell, are partial agonists or low potency versions of these compounds. So I don't think it's really signaling bias, especially because there's a variety of groups that have developed non-hallucinogenic 5-HT2A ligands that have therapeutic potential. Some of them are G protein biased, some of them are beta-arrestin biased. Many of them are balanced. So I really think the partial agonism is the key here.
no postsynaptic versus presynaptic 5-HT2A receptor, something like that?
Now, I think maybe what you're referring to here is, we have shown that a specific population of 5-HT2A receptors within intracellular pools within cortical neurons seems to be critical for the plasticity promoting effects of the drugs, at least in the prefrontal cortex. Others have shown that activation of 2A receptors in other locations might have plasticity promoting effects as well. And so they're not restricted to one particular class of drugs, but we do think that this gives them a little bit of pharmacological selectivity. The targets, the 2A receptors, are only expressed in certain cells and certain brain regions. And that helps, I think, to drive a therapeutic response versus a maladaptive response. We're not promoting, from what we can tell, a lot of plasticity in maladaptive circuits. We're not producing maladaptive behavioral responses when we give these drugs. It's mainly the therapeutic response.
Mm-hmm. Yeah.
Now, there's an open question, though, and that is, what is the exact population that mediates the therapeutic behavioral responses and the hallucinogenic effects? And it is still unclear exactly what circuits mediate the hallucinogenic effects. There's a lot more known now about the circuits that mediate the therapeutic responses, and you can activate those circuits and not produce the characteristic hallucinogenic behaviors of psychedelics. So in that regard, maybe the location of the receptors does matter, but I think the prevailing hypothesis now is that in therapeutic circuits, there's probably a high receptor reserve of 5-HT2A receptors. So a partial agonist is sufficient to get a full response. But in these putative hallucinogenic circuits, you might need a high efficacy agonist to get a full response. And so partial agonists actually act like antagonists in those circuits. And that's one of the reasons we think that these non-hallucinogenic psychoplastogens or neuroplastogens can actually block hallucinogenic behavioral response and have antipsychotic-like properties.
Mm-hmm, mm-hmm. And maybe the hallucinogenic pool of 5-HT2A receptors are the one inducing glutamate burst? Is that
That's a really good point. So we published a paper just recently in Nature Neuroscience where we compared 5-methoxy-dimethyltryptamine, a hallucinogen, to a non-hallucinogenic congener called tabernanthalog, or TBG. And these compounds will produce the exact same level of neuroplasticity in terms of spinogenesis, in terms of EPSC, frequency and amplitude changes after the drug has been cleared from the body, but they have very different acute behavioral effects. 5-MeO-DMT causes a head twitch response. TBG does not. TBG can actually block a 5-MeO-induced head twitch response. Big difference is that 5-MeO-DMT is a pretty full agonist of the 5-HT2A receptor. TBG is a partial agonist. We did a bunch of phybophotometry using a glutamate sensor, as well as microdialysis studies, to look for this glutamate burst that seems to be common to psychedelic compounds. And for a long time, it was hypothesized that this glutamate burst turned on immediate early genes, and then that is what led to the plasticity response. But in this study, we very clearly demonstrated that tabernanthalog produced the same plasticity effects in the absence of any glutamate burst and in the absence of IEG induction. There was absolutely no IEGs turned on, and there was no glutamate surge. But the plasticity effects were the same. Mm-hmm. We extended this to several other non-hallucinogenic psychoplastogens, including zalsupindole. Zalsupindole is in the supporting information in that paper. Mm-hmm. And the non-hallucinogenic agents universally seem to, either don't cause any IEG response or glutamate burst, or cause very, very minimal response. So I do think that this surge of glutamate is probably more related to the hallucinogenic effects of the drugs rather than their plasticity promoting effects.
Mm-hmm. Great. Let's delve into the phase 1 of Delix1. It is not complete. And can you share about a few information about the design of phase 1B or?
Sure. So phase 1A and phase 1B have been completed. The first and most important thing is that in phase 1A, there's over 100 healthy individuals took the drug. It was incredibly well tolerated. Absolutely no signs of hallucinogenic or dissociative effects at any dose. This is not microdosing. You cannot take a high enough dose of DLX1 to produce the same types of subjective effects that you get with psychedelics. So it is definitively a non-hallucinogenic compound. That's the most important thing. In phase 1A, we were looking for some translational biomarkers that might indicate that the drug was engaging brain mechanisms relevant to plasticity. Now, of course, if you give the drug to patients and they all say, I feel normal, then you might wonder, well, did we just create the world's most expensive placebo? Like, is it really doing anything? Is it getting into the brain? And so for that, we really turned to quantitative EEG. And there is a really well-known signature of, call them plastigenic therapeutic modalities. Ketamine does this, psilocybin does this, and ECT does this. The thing I'm talking about is changes in slow wave rhythms. Excuse me. So it's well known that electroconvulsive therapy, the most effective antidepressant treatment out there, produces very robust changes in the power of delta and theta frequencies in EEG. And so that is what we were looking for with DLX1. And, we saw this in the healthy volunteers that after they got the drug in a concentration and time-dependent manner, we saw increases in delta and theta power. And so that gave us a lot of confidence going into a phase 1B study with patients with major depressive disorder, that we might be able to use this as a translatable biomarker relevant to neuroplasticity. Now, for the listeners out there might be wondering, how is this related to neuroplasticity? Well, the general hypothesis right now is that when you induce spine growth, delta and theta rhythms are then produced in order to produce that homeostatic culling that I was telling you about before. It's called the synaptic homeostasis hypothesis. And this is why, slow wave activity during sleep is so important. It's to kind of cull back all those extra spines and to kind of preserve your signal to noise ratio. And so we were hoping that this might be a marker of that structural plasticity that we see in preclinical animals.
Oh, super interesting.
Oh, sorry. You asked me the question about what is a phase 1B design. I probably should answer that.
Yeah.
Sorry. So that was the translatable biomarker.
Right.
So now phase 1B, we wanted to test patients with major depressive disorder. And so in this design, we're going to enroll roughly 20 patients. And so for the first half of those, about 9 patients, we gave them 7 days of zalsupindole. So you gave it every single day for a week, and then we stopped. And then we followed them for another 4 weeks, no dosing. Sent them home and just followed their progress.
Why did you decide to go for subchronic when a single dose could have?
The reason, quite frankly, was because we could. Zalsupindole was so well tolerated that we could dose it every day. And actually, we've gotten chronic tox back now, and you could dose zalsupindole every day forever if you wanted to. Like it's that well tolerated. And so we didn't want to underclub it. We didn't really know, quite frankly, what dosing paradigm would be the most efficacious.
Right.
And so we wanted to test that hypothesis earlier rather than later. But subsequent, future trials will be more optimized for dosing, and that will likely change. But you can't give psilocybin every day. You can't give 5-MeO DMT every day. You can give zalsupindole every day. So we wanted to start there. So we gave them 7 doses, but then we stopped again because it's a plastogen. It should have sustained effects. It should have rapid and sustained effects. And we found that after the week of dosing, the first day we measured the depression scores, we found that we got a 50% reduction in the depression scores, effect sizes that were very comparable to what have been reported for psychedelic trials. And the really interesting thing was the effect persisted. It lasted for the entire 4 weeks. Patients did not get more depressed. They got better, and then they stayed better. But to answer your question, well, if this is a plastogen, we still don't know exactly how to dose it. That is kind of that's the biggest challenge with being the first neuroplastogen in the clinic. The biggest unanswered question is, what is the optimal dosing paradigm? What is the frequency of administration? We started thinking about how is ECT and ketamine administered? They're given, a couple of times here and there, ECT 2 to 3 times a week for a few weeks, ketamine once a week for 6 weeks. We don't really know, where we should be there. So the next thing we did is we took the next 9 patients and we gave them a dose on day 1 and day 4, and that was it. And we saw the exact same therapeutic response. At day 8, 1 week after dosing, they had the exact same magnitude of effect, and it was sustained for 4 weeks. So I don't know, could we get the same effect with 1 dose? Maybe. That's a question that will have to be answered in future clinical trials.
That's very impressive. Congratulations on that. That's very promising, and yeah, a lot of hope there. So you believe, now we're forced to believe, but do you believe robust therapeutic efficacy is achievable without DMN, default mode network disruption?
Well, default mode network disruption, we never even tested that. That's typically done with fMRI. Most antidepressants tend to do this. Even SSRIs will impact the default mode network. It's not really something that we've been focused on, because what we really care about is that structural plasticity. We're looking to try to physically heal damaged neural circuits, and so we've been looking for biomarkers that are more related to that effect.
Right. It's just that idea that the more challenging a psychedelic experience can be, the more therapeutic it is. That to me lies somewhere in this disruption of the DMN lies the therapeutic, or at least maybe some therapeutic virtue. And
this is not an either or story. I mean, I do think that psychedelics have their place in neuropsychiatry, and some patients can be helped with them.
yes,
It's more about an accessibility issue and
right.
how many patients can you really reach. With a compound like DLX1 that is so well tolerated, it's positioned really well to be a first switch after generics. So you're never going to beat generics because they cost pennies a day. And so, people are going to start on a generic. If they don't get better rapidly, well, then the next option might be something like DLX1. Because DLX1 works so quickly, you'll find out very, very soon if, it's going to be right for you. And if it isn't, then you move up to these other additional therapeutic modalities, whether that's, adding psychological support and therapy, whether that's in clinic ECT, whether that's in clinic psychedelic administration. That's why those are really reserved for treatment resistant populations. They're going to be fourth line kind of treatments. But that's why we went for major depressive disorder, because we think that DLX1 with its safety profile, it can be given so much earlier. And you don't necessarily have to have a challenging experience in order to get better. We know this with even traditional antidepressants.
Yeah. So I see how you position DLX1 in the market. That's very interesting. DLX1 is currently the most advanced non-hallucinogenic neuroplastogen in humans, and so it must have been very stressful for you to advance. To be the first, all eyes on you. How do you handle that pressure scientifically and operationally?
Well, I think that it's always hard to innovate when you're doing something that no one else is doing. There's always going to be a lot of naysayers until they see the data. The proof is in the pudding, and so it's a lot of trying to convince people that this has a chance of success, to raise the capital that you need to run the trials to get a result like we had today, where now people say, oh, it did do exactly what you hoped it would do. It is orally bioavailable. It is extremely well tolerated, and it produced an antidepressant response with a biomarker of neuroplasticity. So, along the way, of course, it's challenging. But what I think we've benefited from is a lot of the work that has been done on the first generation hallucinogenic compounds. They are really the snowplow that is paving the way for us. They are the landlines to our cell phone. I think that neuropsychiatry, a bigger change, a bigger paradigm shift, is the idea of using an agent that produces a rapid and sustained therapeutic effect, using these as kind of chemical catalysts for healing, not, a pill that you have to take every single day for the rest of your life to feel better. You're really taking something to heal damage and produce lasting effects. That's what the first generation compounds are clearly demonstrating in a lot of these clinical trials. And that has made it a lot easier for us to kind of follow on behind. We are the option that produces the very similar rapid and sustained therapeutic efficacy, but with added convenience and scalability. And that's where, the landline to cell phone analogy comes in. Landlines really revolutionized communication, but the cell phones is really what made it accessible to everybody.
How do you see the role in therapy, for the role of therapy, with DLX1?
Well, it's important to note that the way we're doing our trials is a monotherapy. We are just looking at the therapeutic effects of the drug alone. And if it shows therapeutic effects, it have a much easier path to approval from the FDA. But that does not preclude doctors from using it in combination with therapy. We should all be so lucky to have a really competent therapist that we can afford. Everyone knows that if you append therapy to pretty much any intervention, you're going to get improved responses. Mm-hmm. But clearly what we're showing now, and what some of the psychedelic companies are showing as well, is that therapy is not necessary to get a robust therapeutic response.
Mm-hmm.
The added advantage that DLX1 has compared to some of the psychedelic compounds that need to be administered in the clinic is that you could conceivably, pick this up at your local pharmacy, take it at home, and then you could go to an appointment with your therapist, or you can hop on Zoom and have a virtual appointment with your therapist. And so it actually opens even more doors than having to do the in-clinic administration with in-clinic therapy appended to it.
Let's delve into TBG and JRT, which are two other products that you are currently developing. I find JRT super interesting. Maybe we could talk about that compound for a minute. And how did you discover JRT, and how did you discover that a simple swap of C3 to N1 on the LSD scaffold was enough to dim hallucinations?
Yeah, so JRT is one of my favorite compounds. I absolutely love it. And so for those of you who aren't familiar with it, basically what it is we took LSD, and the way I like to describe this is we did a molecular tire rotation. We took two atoms and we just changed their positions. That's it. So JRT has the overall same molecular weight as LSD. It has the overall same shape as LSD. Other LSD analogs like glyceride or 2-bromo LSD have been made, but they are fundamentally like a different shape than LSD. The analogy I like to make is if you have a car, glyceride or 2-bromo LSD like cut off the roof and turned it into a convertible, or added a spoiler, or they did something to change the structure. What JRT did was just swap the tires, and now the car handles better, performs better. And so the way we designed this,
rainy weather.
Pardon me?
In a rainy weather, like
rainy weather, yeah, exactly.
Depressive state, rainy weather, yeah.
So the way we designed this was rationally. So we knew a couple of things. Number one, we knew that with the tryptamine scaffold, if we swapped those two positions, we could reduce hallucinogenic potential. Actually, zalsupindole is an iso-DMT that takes advantage of this transposition. We did not know if the same transposition would work in the ergoline scaffold or not. The next thing that we did is we took a lot of the really beautiful structural biology that had been coming out of labs like Brian Ross' lab and Sheng Wang, and we knew that there was a key interaction with a serine residue that really changed the residence time for LSD. LSD binds and then it kind of gets stuck, and there was this key hydrogen bond that seemed to be mediating that long-lasting interaction. And so we thought that if we could disrupt that hydrogen bond by making this transposition, we could dramatically accelerate the off kinetics of JRT and then lower its maximal efficacy at the receptor, but maintain the potency. And that is what turned out to be the case. The off kinetics, JRT is about 10 times faster off than LSD. Its Emax is, reduced by, compared to LSD by, depends on the assay you're using, but maybe 20% or so. So now it falls into that non-hallucinogenic range, but it is still extremely potent. It's more potent than serotonin. So it's a very high affinity compound. The other thing that I really love about it is that indole NH on LSD makes important interactions with a variety of other receptors, including dopamine receptors and adrenergic receptors. And so we thought it might be contributing to some of LSD's like polypharmacology and its, promiscuous effects that might be contributing to some of its hallucinogenic potential. JRT, by making that transposition, becomes incredibly selective for just the serotonergic system. It doesn't hit dopamine receptors anymore. It doesn't hit adrenergic receptors. And so we have a much more selective pharmacological agent compared to LSD.
Yeah.
I don't know. I can go on forever about JRT, but what I'll tell you from the recent paper, it came out in PNAS this past year, is that it's produced really robust effect sizes in behavior, but also in neuroplasticity. In cellular assays of neuroplasticity, it performs as well or better than LSD. In vivo, we actually did electron microscopy with my colleague Uri Manor at UC San Diego, and we can actually see the synapses that are formed. We see restoration after stress-induced, cortical neuron atrophy. We see effects in assays relevant to both the positive, negative, and cognitive symptoms of schizophrenia. Now, the reason we wanted to run those types of assays is because you're never going to take a compound like LSD into a patient population that has schizophrenia.
Right.
Now, a non-hallucinogenic variant could have major advantages there, particularly because one of the biggest hallmarks of schizophrenia is cortical atrophy. And it is believed that atrophy underlies not only the positive symptoms of the disease, the hallucinations, but also the negative symptoms like the depression and the cognitive symptoms. And so if you've got a non-hallucinogenic agent that can reverse this cortical atrophy, you might have something that can impact all three domains.
Yes, maybe something more than spinogenesis, maybe harborization of the neurons would be necessary, but spinogenesis might help as well. Yeah.
Well, JRT seems to do both, at least in vitro. In vivo, we've only tested spinogenesis and synaptogenesis. Hard to kind of look at full dendritic arbors in vivo. It's incredibly laborious.
Yeah.
But in vitro, it does promote dendritic arborization as well.
I'm surprised that swapping or transposing that nitrogen doesn't, build hydrogen bonds with somewhere else in the pocket of other receptors, but it increased selectivity, you said. So that's really remarkable.
Yeah, it seemed that hydrogen bond was really critical for binding to the other receptors, not super critical for binding to the 5-HT2A receptor, but was important for the kinetics and for the maximal efficacy.
Great. Could you say a few words just about the TBG and here the synthesis strategy? You used a different strategy here where you identify the the core active pharmacological core of ibogaine and decide to trim what was non-essential and especially more hallucinogenic in ibogaine to come down to that compound that is TBG.
Yeah, so I think TBG is important because it was the first neuroplastogen to demonstrate in vivo efficacy. So we published this in a 2021 paper in Nature. And the way we got it at this structure was we used a technique called function-oriented synthesis. It's a technique that's been pioneered by chemical biologists like Paul Wender. And it's really a simple idea. You take a complex natural product like ibogaine, and then you chop it up and make simpler analogs. And you see if those simplified analogs can still retain the beneficial effects and get rid of some of the undesired effects and actually like improve synthetic efficiency to get to the target. So when we looked at the structure of ibogaine, we noticed it had kind of three major motifs. It had an indole, it had a 7-member tetrahydroazepine ring, and it had an isoquinoline, this bicyclic structure. And so we started just deleting the various aspects of that. And what we found was that if we deleted the isoquinoline, but left in the indole and the azepine, we still promoted plasticity. But if we did the opposite, that wasn't true. If we deleted the indole and left the isoquinoline intact, or deleted the azepine, then we did not really get robust plasticity effects. So that allowed us to simplify the core of ibogaine into basically a conformationally restricted 5-methoxydimethyltryptamine. That compound had lower hallucinogenic potential, but it wasn't completely devoid of hallucinogenic potential. So then we played another little trick. We noticed from all of the other structure-activity relationship studies done on tryptamine scaffolds that a methoxy group in the 5 position usually led to hallucinogenic effects, but a methoxy group in the 6 position usually led to non-hallucinogenic agonists. And so we just moved the methoxy one carbon over, And then now it started to resemble a natural product in the iboga family called tabernanthine. And that's why we named the compound tabernanthalol. Tabernanthalol, because it was the first neuroplastogen to be tested really in vivo, has a ton of mechanistic data now on it, really demonstrating that its partial 5-HT2A agonism is really the key for producing a lot of its therapeutic behavioral effects and definitely its cortical neuron growth effects.
There was also the cardiotoxic property. You had to screen that as well. And I'm interested also in ibogaine is hallucinatory, but is one of the strongest hallucinatory compounds there is. It's a very long trip.
Well, I think that might depend. So the first thing I'll say is about the cardiotoxicity. So ibogaine's big issue, I think, is really it's the fact that it binds to hERG channels in the heart and can cause cardiac arrhythmias. The reason it's such a good binder of hERG is because it's a greasy cation. hERG loves greasy cations. So by chopping off the isoquinocodeine, which is really just a bunch of grease, we dramatically reduce the potency of tabernanthalol for hERG, about 150-fold reduction. So now we don't have the cardiotoxicity issue that has plagued ibogaine. Now, in terms of the hallucinogenic potential of ibogaine in the clinic, the way it's used now, at least anecdotally, is people are given massive, massive doses. It's unclear to me how low you can dose to still get a therapeutic response. When ibogaine used to be on the market in France, as an antidepressant agent, and it was used in very low doses. So, it's unclear to me if ibogaine is truly hallucinogenic or if it is, at more reasonable doses, has therapeutic effects without the hallucinations. I think one of the reasons that maybe it's, has these very long-lasting, strange hallucinogenic experiences because it's a grease ball. And people are taking massive amounts of it. It's getting stored in the fat. It's getting released for a very long time. It sticks around. And so, I think going to more reasonable doses would probably help in terms of its hallucinogenic potential. People are taking grams of that compound. If you take a gram of Benadryl, I'm pretty sure that you're going to have, very strange effects.
Mm-hmm. Mm-hmm. All right. Well, thank you so much. One last question, David. How do you see psychoplastogens and classical psychedelics coexist at scale in the future?
Yeah, well, I think that, the first generation psychoplastogens are going to be the first to be approved. They're getting very, very close. And that's very important because patients need help now. And they will definitely help some patients. The problem with the first generation compounds, again, is the scalability, the cost and the complexity of the treatment. You really need to administer them in the clinic under the supervision of usually multiple healthcare professionals, and that costs a lot of money. And so I think that they are going to be reserved for select cases, either for people who have tried a lot of other things and have not gotten better, or maybe for very specific indications where a hallucinogenic experience could be very, very beneficial. I'm thinking of things like anxiety from a terminal cancer diagnosis or something like that. You might actually want to have that kind of hallucinogenic subjective experience to kind of reevaluate your life and come to terms with, the inevitability of death. That could be a huge advantage for them in psychiatry. So there will be certain cases where they will be a very useful tool. But when we think about the fact that 1 in 5 people will suffer from a neuropsychiatric disease at some point in their lifetime, we're talking about 1 billion people worldwide. We cannot treat 1 billion people with an in-clinic compound like a psychedelic. We need more scalable take-home medicines. And that's really where I see the neuroplastogens coming in. Now, if I had to look into a crystal ball and predict where the field's going to be 10, 20 years from now, I think that in 20 years, every major pharmaceutical company will have a plastogen product. Could be a psychoplastogen, could be a neuroplastogen. They might have combinations of both to fill the need. And I do think that because plastogens in general have such a broad therapeutic potential, I think that they're going to be used beyond neuropsychiatry. I think they're going to eventually be used for neurodegenerative conditions. I think they're going to be used for recovery after neurological insults like traumatic brain injury and stroke. That we're just seeing the tip of the iceberg with what plastogens can do. I think it's going to be just a major therapeutic modality, 20 years from now.
All right. Well, thank you so much, David, for your insights today. That was very uplifting, promising, encouraging, and wish you all the best at the IPN and at Delix.
Thank you.
Thank you, everybody, for tuning in. If you have any questions, please message me. I can send you the transcript of this conversation as well. And in the meantime, until our next talk, be well.